Good morning, everyone. My topic is clinical assessment and treatment methods in case of traumatic submacular hemorrhage. A 14-year-old female came with a firecracker injury in her right eye on her second day. She complained of sudden painless loss of vision in her right eye while there was normal vision in the left eye. There is no history of redness or pain in the eye, no other prior history of ocular surgery or trauma is present. Her ocular examination, the vision is hand movement in the right eye while it's 6/6 in the left eye. The other ocular findings are normal. Anterior chamber findings are normal, while in the pupillary reaction, in the right eye there is RAPD grade 3, while there is normal pupillary reflex in the left eye. The IOPs of both the eyes is normal and the lens status is phakic and there is no lenticular opacity. In the dilated fundus examination, in the right eye there is a dull foveal reflex with a large bright area of around 4 disc diameter with central 2 disc diameter grey area of RPE changes, along with the presence of there is crescentric choroidal tear with tapered and nasal to the macula. Now coming on to the OCT, in the right eye we can see there is a dome-shaped elevation of central retina with loss of foveal contour. The pre-retinal and intraretinal area is normal, while there is a collection we can see in the subretinal area with shadowing. We cannot comment on the RPE status because of the presence of shadowing. Here we can see there is a central macular thickness of 397 micrometers. Then the approach after the thorough anterior and posterior segment examination, the single dose of intravitreous anti-VEGF ranibizumab was administered on the same day of presentation and she was put on weekly follow-up. There was no improvement of vision was seen in the second week and hence she was planned for pneumatic displacement with intravitreous C3F8 gas and was advised lying prone for the 2 days. After 2 weeks we can see the vision had improved to 2/60. On the 4th week her vision was 3/60 and she was given another injection of ranibizumab. She came for the follow-up 2 weeks later when her vision came to 5/60 following which there was no further improvement. Here we can see this was the OCT image after 4 weeks when she came up after 1 month of the second injection. There is presence of foveal contour. The pre-retinal and intraretinal level is normal, while there is collection here we can see at the subretinal area and minimal shadowing is present. Now discussion. Submacular hemorrhage is a catastrophic sequelae of several disease processes and leads to considerable visual impairment. The management options for treating submacular hemorrhage has undergone paradigm shifts over the past decade. Giamberto Cassini et al. Recommended pneumatic displacement with prone position in young patients. The role of anti-VEGF agents is more defined in the patients with associated posterior segment pathologies. Here we can see that anti-VEGF is only performed as an adjuvant treatment. Alone, anti-VEGF had no role. The PPV with subretinal or intraretinal TPA with gas tamponade is the recommended standard treatment. Conclusion. The traumatic submacular hemorrhage has unfavorable evolution and persistence of blood, which causes photoreceptor toxicity, warranting timely intervention. In our case, the initial treatment with anti-VEGF showed no effect. After further gas tamponade, we could see the resolution of hemorrhage with vision improvement. The management options for treating submacular hemorrhage has undergone paradigm shifts. Hence, we can conclude that early and appropriate intervention are the key determinants of the final prognosis. Thank you.
What is the standard management of traumatic submacular hemorrhage?
So, according to the literature, the standard management is the past skin vitrectomy with the pneumatic displacement is done along with TPA, subretinal TPA. We did not perform subretinal TPA at our center. But
why subretinal TPA?
So because of the presence of submacular hemorrhage, there is deposition of
subretinally.
So they have seen that the when TPA could be given subretinal as well as alone as well. But they have seen, the literature has seen that the subretinal TPA has a better prognosis.
A role of anti-VEGF?
So as in my case as well, So when we gave anti-VEGF before the pneumatic, there was no improvement in the vision. It's only acts as an adjuvant treatment. So the literature is not completely present here as to what should be done about the submacular hemorrhage.
So there is no rule of anti-VEGF in submacular unless there is a CNV.
That in my case, that it's only used as an adjuvant treatment.
See, what is the primary thing that you want to do when you want to attend these cases? What is the primary function that you want to achieve?
So to exactly evaluate how should be.
No, I think the primary thing only in this case is to shift the hemorrhage from there, from the macula. That's the only thing.
Yeah.
Okay, so it can so only just gas or gas with just intravitreal TPA can also do it. If you have a very large hemorrhage with a detachment or something, then you go ahead and do a vitrectomy. But other than that, I think just giving an anti-VEGF in the beginning is really not. And I think you also said in your discussion. So I think that is really not required. So the primary concern is to save the macula, so you kind of shift the hemorrhage. Yeah, that's the basic thing that you want to do. And then obviously there are further investigations that you can do to see whether you want to intervene again. Because ultimately there would be a breakthrough somewhere and this will come into the vitreous cavity.
Yes.
Right? But the primary concern is to shift it from the macula. That's the main thing.